always. Thanks for giving me the floor to be able to present some of these important updates. There's a lot going on, as always. Um, it's not the first time probably that you've heard me say that policy moves both very quickly and very, very slowly. And so that's something interesting to grapple with all of the time. But today, Jill asked me to focus the presentation on the CMS final rules that we got this year, or went into effect on January 1 of this year. So as a quick refresher, proposed rules that we care about primarily in the rural health clinic setting, the Medicare physician fee schedule, and the outpatient perspective payment system proposed rules both come out every July. There's about a 60-day comment period typically where we have the chance to digest all of that information, determine how it benefits or perhaps hurts the RHC community. We provide comments, but everyone is allowed to do so as well directly to CMS. CMS takes all those comments once that comment period closes and then works them into their final rule, which is released sometime in November. And then the provisions that are finalized there go into effect on January 1 of the following year. So what we're talking about now is CY 2024 final rules and the impacts for RHCs based on those. A little bit about our organization, which thanks to our great collaboration with Jill and her team in Michigan, I think you're well aware of, but I have the privilege of working in our DC office and advocating on behalf of the 5,400 plus rural health clinics across the country. The program as a whole serves over 37 million patients. And so that is one of my favorite metrics to share with folks on the Hill and members of the administration. The impact of this program is quite significant and far-reaching. And so thank you to all of you for all the work that you do. And I get to share that in Washington, D.C. And advocate for important changes to the program. So additionally, we do a lot of technical assistance work, have some educational offerings, and then that gives me the chance to chat with all of you. So the first thing that I wanted to highlight is the finalized reimbursement rates for some of our special payment rules that we're subject to. So these are obviously things outside of our traditional encounter or what would qualify as an encounter in the rural health clinic. Those traditional encounters obviously reimbursed at your RHC's all-inclusive rate. These are outside of that. So they're things that are carved out of your cost report calculations, not paid at your all-inclusive rate, special payment rules, as we call them. This includes care management, which we'll talk about a little bit later in terms of some changes that went into effect this year with care management, but you can see that is subject to a special payment rule here. Psychiatric care management, digital e-visits, telehealth visits, so how we're currently reimbursed for telehealth. This is policy through December 31st of 2024 at least. Congress will have to take action or pass legislation sometime before December 31st in order to avoid telehealth flexibilities reverting to those really limited pre-pandemic policies that we once were subject to. And so while I'm not going to spend a lot of today's session talking about telehealth and things on the legislative side, given there's enough on the regulatory side, it is important to be aware that that's where a lot of our advocacy focus is going to be this year is on telehealth advocacy, given that it's such a big year and Congress does have to take action to avoid that going away. But G2025 is another example of our special payment rule. You can see the change from 2023 to 2024 with these reimbursement rates. The reason for fluctuations here really has to do with the fact that for each of these, they're consolidated codes based on a whole host of codes on the fee schedule side, as reimbursement rates for those individual codes making up this consolidated code fluctuate a bit based on things on the fee schedule. On the fee schedule side, conversion factor issues, that accounts for some of these fluctuations. I will say, even over the last few weeks, these 2024 reimbursement rates have fluctuated slightly. So I think when we did our final rules webinar NRHC, the G0511 2024 rate was like 71.69. So those are like the amounts that it's fluctuating by. But if you see some different reimbursements in different locations, that's likely why. The link at the bottom of your screen is to the CMS website that the most updated reimbursements are posted. So we'll try to ensure that ours are the most up to date as well. But if you see some cent by cent fluctuations, that is why. Okay. So the number one, or the first one that I'm going to cover in no particular order, big change in this year's final rule is the addition of 2 new billable provider types in rural health clinics eligible to generate an encounter and therefore your clinic's all-inclusive rate. So it's been quite some time since a provider was added to the list of qualifying providers in the RHC setting, but was done beginning January 1st of this year. These provider types are marriage and family therapists and mental health counselors. Mental health counselors is a bit of an umbrella category or an overreaching category in the sense that every state oftentimes defines these providers a bit differently. Mental health counselors, clinical professional counselors can all meet the definition laid out here. The nomenclature in your individual state might just be a little bit different. The important piece is that they meet the education, licensure, and certification, and then that clinical supervised experience hours or time frame in order to enroll as mental health counselors within Medicare. But they are very specific that they intended to use the broader umbrella category in recognition of the fact that every state calls them something slightly different. Okay, so these are all the places in the RHC regulation that CMS had to alter in order to incorporate these new provider types as reimbursable providers at the RHC's all-inclusive rate. So that may be helpful for you. It may not be, but what's in the box at the bottom of your screen is really what those changes in the regulation did. So basically means marriage and family therapists, mental health counselors can generate a Medicare encounter reimbursable at the rural health clinic's all-inclusive rate, as I said previously. These providers are subject to the same policies as your other APPs. They can serve as the RHC owner, an employee of the clinic, or be under contract. And this is an important one. Marriage and family therapists and mental health counselors, CMS has said, can fulfill the requirement that a provider must be available to furnish care at all times the clinic is open. And then CMS has released some additional FAQs on enrollment of these providers and things like that, which are linked in these slides, which you should have access to as well. But this was a big change. I'm curious to hear how rural health clinics start to utilize these provider types. I know that in some states they were already reimbursable under Medicaid, and so perhaps some clinics were already utilizing them. But obviously now that they can generate your all-inclusive rate for your Medicare population, this may be something to look into if perhaps these provider types are more available in your communities, in your state, perhaps. So something certainly to be aware of.
Sarah, quick question in the chat.
Yeah.
Can peer recovery coaches bill for services?
Yeah. It's a good question. If they meet this definition under mental health counselor, they could enroll as mental health counselors with Medicare and then be able to. CMS did say that specifically called out addiction counselors who meet these requirements can fall into this category, depending on, again, what your state licensure and certification looks like. I'm not 100% familiar with that provider type specifically. So I don't think I can give a better answer there, but I would direct you to this specific definition of a mental health counselor. And if they meet that, they can enroll in Medicare as such.
Thank you, Sarah.
But that's just an example of like the different nomenclature that perhaps different states use. Yeah. Okay, moving on to the next big change that was included in final rules this year, intensive outpatient program services. So rural health clinics can now furnish IOP services and be reimbursed also under another special payment rule. This is getting more and more common in the RHC setting, but this is a behavioral health treatment category intended for your patients that need something between an occasional outpatient office visit, but don't quite rise to the level of needing partial hospitalization services. So they've defined this as 9 to 19 hours of care per week. And again, these services will be reimbursed through a special payment rule, not your RHC's all-inclusive rate. These services are to be provided in person and not through the utilization of telehealth. Now, if you're doing mental health services via telehealth, that's perfectly fine separately, but those services or encounters cannot be part of the provision of IOP services and billed that way. The special payment rule details around that. This will reimburse right around $260 per patient per day. That $260 reimbursement corresponds to 3 distinct qualifying services per day. And there's more information linked here as to what those specific services are, but essentially, one of the services needs to come from one specific list, the primary list, as they call it, and then the additional services to make up the 3 qualifying services per day come from this additional supplemental list. So if you have questions about that, if you're looking to start up an IOP program, this is brand new for RHCs, and so we're learning a lot. But originally, when this regulation came out, I was thinking this is going to be pretty significant upfront investment, require probably quite a bit of space and all of those things in the RHC setting. And so while we were pleased to be included as eligible billable providers, I wasn't thinking that uptake probably in RHCs was going to be super high. I'm pleasantly surprised to hear that quite a few RHCs are considering at least or in initial conversations about creating an IOP program. I think that really shows the need in the communities that you're serving. But it also means we're doing a lot of like peer-to-peer sharing about what's feasible and that kind of thing. So curious to hear if any of you are kind of interested in starting up a program like this, what perhaps your limitations or challenges may be from an advocacy perspective as well. You know, CMS put this into regulation and promulgated this rule based on what Congress passed into law. So kind of following that statute to regulation pathway within their authority. But there are certain areas that perhaps if we're hearing this isn't feasible because of X in the RHC setting, that's something that we can kind of go back to CMS and to Congress if necessary to remedy or see what we can address. So that's why the feedback loop I think is really important if you are considering implementing any of these services.
Sarah, real quickly,
There's some,
one
yeah.
other question in the chat. The same type of question as previously in terms about providers. What about licensed health coaches?
Not to sound like a broken record, but I'm going to sound like a broken record a little bit. I unfortunately do not know the nuances of individual providers and what their licensure looks like. Again, if they meet this definition, CMS has not limited the type of providers by their name specifically. So if they meet all of what's sketched out here, even if it is a different name, they've been clear that they could enroll as those providers. So if there are a lot of these types of questions, I'm happy to do my best to look into some of these other providers and get back to some of you that have specific questions. All I have to lean on right now is this definition here, but I certainly can dig into some of those other providers if you send them my way. My contact info will be at the end. but without having the time to dig in, I unfortunately have to just punt kind of back to this definition.
Thank you, Sarah.
Okay. Yeah, of course. So all the details on IOP that we have thus far are in this slide and linked in the resources here. But like I said, this feedback loop I think is really important, particularly on new services that we have the opportunity to provide. So I'm happy to chat more about this. Okay. Um, Probably the biggest change in terms of something that we've been advocating pretty heavily on for the last few years is around changes to care management services billable in the rural health clinic setting. Um, so CMS made two main changes this year as it pertains to care management services and that G0511 billing. So first and foremost, they added 4 new buckets of care management related activities. So we have the G0511 code, and that represents general care management services, is how it's defined. That's becoming a larger and larger bucket or consolidated code. It used to be just chronic care management, and now we have chronic care management, we have principal care management, we have chronic pain management. And then beginning in 2024, we also have RPM, RTM, and then 2 brand new services for all of Medicare, community health integration and principal illness navigation services. So those 2 are brand new for everyone. RPM and RTM fee-for-service providers have been able to bill for several years now. RHCs and FQHCs could not until 2024. So I'm going to jump back and forth between a couple slides for a minute. So in 2023, these were all of the services that if you performed, you would bill as G0511. A consolidated code. Again, you got around that $70 reimbursement that I showed on the first slide. These were all the codes that went into that G0511 code. In 2024, these are all the services that kind of make up the general care management or G0511 bucket now. So obviously we expanded this pool quite a bit. You see all the bolded codes are the new ones. So this includes RPM, RTM, and then those community health integration, principal illness navigation services. The community health integration and principal illness navigation services, like I said, these are brand new, so we're learning a bit more about what this could look like and utilization of these. But it's intended to utilize some of your community health workers and others that we know are doing more of those social and care supports beyond a traditional office visit, but perhaps there hasn't really been a reimbursement methodology for them before. So now if you provide any of these services, you would bill G0511, get around that $70 reimbursement. Now, in 2023, and previously, the guidance from CMS very explicitly said that G0511, despite representing all those codes, could only be billed once per patient per month. And so even if you did some of those other services, you were limited to that one billing and one associated reimbursement. Another big change that went into effect in 2024 is that CMS is now allowing multiple G0511s per patient per month, so long as resource costs and time are not duplicated between the services. So now, if you have a chronic care management program in your RHC and you bill for CCM services provided to your patient as G0511, you get that $70-ish reimbursement. You can also perhaps implement an RPM program for your patients, same patients that are already enrolled in chronic care management, and you would be eligible to bill a second G0511 per patient in the same month. And you would be eligible to get that additional reimbursement. So this is positive. Otherwise, they're kind of adding codes, and if we do the services, we still don't get the additional reimbursement, right? That was previous policy. So that's good to hear. They were very explicit that if we're not double counting resource costs, we can bill it multiple times per patient per month. The issue here, though, is that we don't really know yet how many G0511s is acceptable per patient per month. So, you know, if you have a highly, highly complex patient, many of the patients that you're treating, and you use community health workers, you have an RPM program, you have a chronic care management program, you have a general behavioral health integration program, perhaps. You know, reasonably, we could, without double counting resource costs, see the potential to do all of those services for that same patient, but that would result in 4, 5, 6 G0511s on the same claim for the same patient in the same month. And we could have the documentation to back that up, certainly for our complex patients, but are the MACs going to be able to properly adjudicate 6, perhaps, G0511s on the same patient on the same claim in the same month? Because there's no modifier required for these additional G0511s, right? They all show up on the claim as G0511, despite the fact it now represents 22 different services. And so this is what we're waiting for additional guidance from CMS on, is kind of how many, what are reasonable things that could be billed together versus where's that limitation going to exist in, oh, that's too many on a claim for the same patient, that kind of thing. So we're a little bit frustrated because this benefit went into effect over a month ago, right, on January 1st, and we still don't have that final guidance, which we think is what is really going to allow RHCs to feel comfortable operationalizing the new benefits that CMS is allowing for. But we continue to push. We had a meeting with CMS just yesterday again, and it's still in their process. I can recognize they have quite an approval process to go through, but we want to utilize the benefit. And so we're continuing to push there. But that's just a brief update on care management. I know there's lots of thoughts and kind of predictions on what will be allowed and what will not be, but this is as explicit of guidance as we have at this point. I know I'm getting close to time, and I'm sure there are a few questions. I can see that number in the chat increase. I'm not looking at the chat quite yet, but I'll just get through a few more slides and then happy to take a few minutes to answer questions as well. We launched our 2024 RHC survey yesterday. The intent of this survey is really to allow us to gather data on the scope and the impact of the rural health clinic program, as well as make sure the issues that we're advocating on are the issues truly impacting you and your clinics. So I would really, really, really encourage you to complete this survey. It will be open for the month of February, but whenever you have the data and you're able to submit it, we would really appreciate that. So you can scan the QR code. I'll put this also in the chat and make sure that you have access to the link in more ways than you want it, so that you can help us by completing it. But thank you in advance. The surveys like this are what it allows us to have metrics like the 37 million patients that the RHC program serves. That's really, really impactful when I'm advocating on behalf of the program. So appreciate that. And then finally, this is an invite to join us to advocate in person in Washington, D.C. If this is not feasible for you this year or at all, we can certainly find ways to help you advocate separately. But we are having a specific policy summit to give you the opportunity to go to the Hill and advocate on behalf of RHCs and share your clinic story. The story that you're able to share is immensely valuable. I grew up in rural Pennsylvania, but I obviously do not live there, nor do I provide care in an RHC at this point. And so your personal stories are incredibly valuable. Here is the link to sign up for Policy Summit. If you're interested, we would love to share that with you. Resources, as always, and then my contact information. would be more than happy to continue this conversation with you or any questions that we don't get to, given that I'm at or over time, I guess now. But thank you as always for having me and for hearing these updates.